And here we are live for adjusting for you. Okay, joint mobilizations. Oh, and in fact, that's another thing we'll do. Demo it first without a thrust, as though it's a mobilization, and then demo it with a thrust, depending on what somebody's scope of practice is.
Okay.
Okay?
Yep.
All right, so we're coming to you live. Hi, I'm Dr. Nikita Vizniak with the amazing
Dr. Eckle.
And we're going to show you some joint mobilizations that you can do of the hip. All right.
Perfect. I'm going to have you lay on your back for me. So starting with a long axis distraction, we have a few ways we can demonstrate this. Long axis distraction is just opening up the hip joint and allowing for an increase in global range of motion. So the first one I like is going to be just kind of supporting the femur like this. We're going to stabilize at the ASIS and just above the hip joint. And then from there, we can perform a mobilization, just tractioning basically a superior to inferior force on it. Or we can apply a thrust where we're going to stabilize a little bit harder there and do a pull.
So one key point on that one, Amber set it up again for us, it's great, is absolutely make sure, and that time way better too, make sure that when your hand hooks in, you actually have a nice soft contact on that ASIS. It can be an overload for some patients, so just be aware of that. Yeah.
Perfect. I do like to assist with the bunny hop type of mobilization. So we're actually going to go right above the knee joint here. I'm going to hold the backside of the femur, again stabilizing. And here I'm just going to be applying a little bit of a traction, but actually extending my knees.
Yeah.
A little thrust.
So you can do it as a thrust, or you can do it as a mobilization too, right?
So we can do kind of bouncing in and out of that joint play.
Totally. And the really good thing about this is you get to use your strongest muscles against the patient's strongest muscles. So it takes a lot of stress off of your body. Yep. Nice.
Okay, so anything?
No.
Is that on there?
Yeah.
Okay. So an anterior to posterior.
Yep.
Okay. So setting up an anterior to posterior adjustment or mobilization on the hip, we're actually going to be facing the knee joint here. Actually, no, we're not. We're okay. Do we start it again?
Yeah, just start it again. Yeah.
I want to just look at what you do here. A to P glide is what you're calling it?
Yeah. And use the term mobilization first and then adjustment, okay?
Okay.
Yeah.
A to P mobilization or adjustment.
Yeah.
And then fingers, okay.
Yeah.
So we're going to do an anterior to posterior mobilization and adjustment here. We're going to start with the patient's knee inflection. With this, we're keeping in mind the head of the femur, and we're going to be applying an anterior to posterior direction of mobilization or force. So with this, I'm going to stabilize on the back side of the femur. I'm going to take my inferior hand and place it along the hip crease. With this, we want to apply a little bit of traction and then an anterior to posterior force.
So she's just gapping and gliding down a little bit. What you can't see is her elbow on this side is resting on her thigh. Really good stabilization that way.
So with that, we can also do a force manipulation on it. So applying that traction and then an adjustment. This also works well with a drop table underneath.
Yep, excellent.
Next one.
That's what we do.
Is that what we do?
Yeah, totally. Another variation on that though that you could do is you could actually sit where you put both hands, wrap around and pull this way. Sit down.
Sit.
Yeah, let's go ahead and switch down. No, you'll lay down. So another variation that you can do with it is going to be a position like this, and it depends on the size of the patient, but you can basically put their leg up, and now I'm going to go ahead and I can traction straight down, superior to inferior, but really it's anterior to posterior. Not quite as A to P as what Amber demonstrated, but a way that you can pull down, and then you can add rotational components to it as well if you like. Okay, and again, as a mobilization, back is nice and straight, just pulling, or as an adjustment where you tissue pull and then thrust in. Okay,
Yeah, that's a great one.
all right. What's next, boss?
I don't know. A posterior to anterior?
Sure.
Okay, let's go face down.
Okay. So your patient lays face down, and then what?
So we're doing a posterior to anterior mobilization. We're getting as close to the top of the femur as we can. This is going to increase their extension of the hip joint. This is one that's used a little bit less commonly. What we want to remember here is that our patient is extra comfortable.
I am. It's good.
Okay.
It's good. Yeah.
And then from there, we're going to go at that, again, lower gluteal fold, fingers pointed outwards. We can do a support hand. You can see I'm in a kind of a deep lunge here. And as a mobilization, we're just going to apply a posterior to anterior force, keeping our elbow locked out, or we can apply a thrust. Another variation of this would be bending the knee. We're going to grab under the knee, just kind of lifting up, making it easy on myself, and then heel of my hand on as high up on the femur as I can get, with a lift up on the femur, and then a posterior anterior, either mobilization or force.
Okay.
Is that okay?
Yep, great. And that's one of the better ones there to stretch out that anterior joint capsule, all the iliopsoas and all of that good stuff. So excellent. All right.
Which one next?
Look at the list. Okay. Yeah, like we can basically just take a break every time, right? So
okay.
yeah, we just roll for a bit and then we just chop, chop, chop into pieces.
So do you kind of showed these internal external rotations?
I did.
What do you want me to
show? Yeah, I want you to show them again too.
Okay.
Okay.
Can I start with just the SI?
Totally.
Okay, so starting with the superior to inferior traction on the hip joint, we're going to put the patient's knee at 90 degrees. One thing I like to keep in mind is leaving it at 90 degrees, not letting it flail into the air. That just takes the tension out of the hamstring. We are going to clasp our fingers into the hip crease, and first and foremost, we're just going to apply a little bit of a downward traction. So we can play with that joint end range a little bit, and then if we want to do a thrust, we can do a little bit of a pull. From that position, we know that most patients need a little bit of an increase in internal rotation. So we can actually take our tissue slack from outside to inside, pulling into internal rotation, and then applying that same force of SI. The opposite of that being pulling into external rotation, and again, and superior to inferior force.
Yeah, and this is a great setup for somebody with osteoarthritis or hip joint contracture or anything like that. This will be a good way for you to go ahead and mobilize that joint. So yeah.
Those are most of the hip ones.
Okay.
Do you have any other hip ones you use?
Not really. Yeah.
Yeah, that's it.
Okay. You want to bang some knee ones off really quick? Let's just do that. Just bang some knee ones off. Just scroll down. Yeah, keep going. I mean, really, it's quite simple once you get it, but it's like so complicated for students, right?
True.
Yeah.
Okay, so posterior to anterior and anterior to posterior glide.
Yeah. And showing it with like the anterior posterior drawer position and up in the neutral position, like a flex 90s. You can do both.
What is flex 90?
You're just up here and you do the same thing where you push down on it.
Where do you stabilize though?
You just wind up stabilizing against
Like
your hip. Oh yeah,
this?
you can do that totally. That works.
And then applying anterior to posterior.
Yeah, yeah.
That's a posterior glide?
Yeah, yeah. Totally.
Or posterior.
Anterior to posterior glide, if you wanted to say that. Yeah.
And that's a posterior drawer test? Yes.
Yeah, totally.
Okay. That's how often I'm using that. Okay. So first, we're going to do a anterior to posterior glide. This is going to be a PCL test. Yes.
Well, you can't say it's a PCL test, but we're going to use it as a mobilization for a restriction in range of motion, right?
Okay.
Yeah.
Okay, let's try that again.
Okay.
Okay, so we're going to be doing an anterior to posterior glide on the tibiofemoral joint. This would be used as a mobilization or a thrust. It's a modification or I still don't know what the word is.
It's just a variation. So you have a patient come in and they have decreased posterior glide of the knee. This is a way that you can induce some posterior glide of the knee.
Exactly.
Would be contraindicated though if they have an unstable knee or PCL laxity.
So always starting this one with a mobilization is key. I like to kind of hold down the foot if possible and then line my thumbs up onto the tibial tuberosity. And from there, we're going to apply a little bit of an anterior to posterior force. If we want to do more of an adjustment on it, we would do one quick thrust.
Okay. And then a variation on that is?
Variation of that would be at 90 degrees. We're going to keep them right in that position, applying the same force downward.
Yeah. And if you want, it depends on your height to the patient size. Amber and I are about the same height, but if you were a smaller person, you could actually lean more over top of the knee and get your chest right over top of your hands and generate good force down that way. So whether it's a mobilization or a grade 5 mob, you can go ahead and do that.
So we're going to do a posterior to anterior glide. We are going to hook on the back sides of the knee joint here on the tibia, and we're going to be stabilizing with my knee on his foot and just doing a gentle pull first as a mobilization, going posterior to anterior. This would increase the posterior and anterior glide of the tibio-femoral joint.
Yeah,
and
challenge mostly the ACL as well. Yeah, and you can change it into a grade 5 if you want. And you can also do that with some rotational components if you wanted to. So if you turn the... Yeah.
So we can put the foot into external rotation with the same pull, or internal rotation, pending if you see one of the condyles locked up more than the other.
Yeah. And again, that's going to come with more experience as you assess more and more knees. All right, what else?
I like, I don't know if you have it in here, but I do like the bunny hop on there.
Okay.
With, do you have that?
No, but we have it as a different one, but do it as a bunny hop here too.
Okay.
Yeah. So yeah. Yeah.
I like, I don't know what I would call it. Just a traction on
a knee long axis distraction.
Okay.
Or traction. Yeah. So this next adjustment is a?
So this next adjustment is a long axis distraction on the tibiofemoral joint. We're going to use a bunny hop maneuver here. So I'm going to just hook his ankle in between, right above my knees. I am going to put my thumbs on the eyes of the knees, aka the condyles of the tibia. From there, I'm going to get my patient to stabilize himself by holding the table down. The knee, you can see it's in slight flexion, and we're going to pull it into traction with a little bit of extension on the force.
Yeah, nice. And if you wanted to, you could also add rotational component to that as well.
Yeah.
By predisposing the ankle.
Exactly.
Yeah.
So we're going to do the same traction on it. And if I want to open up, just be opening up more of the
lateral side.
Lateral condyle.
Yeah.
So if I want to open up the lateral condyle, I'm going to do a little bit more traction on that side. The foot is, or the tibia is in internal rotation with a bit of a pull. We can open up the medial condyle with a little bit of an external rotation on it and a bit of a pull.
And just one thing I want everybody to observe when you're watching this, watch when Amber moves. Like, she has got coordination of movement. Her knees go at the same time as her hands pull. All that happens while the patient is holding. If the patient doesn't hold and you're really doing this, you're just going to be pulling them down the table, right? So
slide with them.
Yeah.
M to L and L to M. You like that in like just slight flexion, right?
Yeah.
Okay, we're going to be performing a lateral to medial on the knee joint here, on the tibiofemoral joint. So I'm going to have my patient's knee in slight flexion. I'm going to use the web of my hand on the lateral aspect of the joint. I'm going to be putting a little bit of a valgus force on the tibia, and then you can see my forearm is going to go perpendicular to the joint, and we're going to go lateral to medial.
And so you can use that as a mobilization to start. And another tip that you might consider is when you're doing this, again, Amber's really strong, but if you're not so strong in the upper body, you could put your elbow inside of your thigh and actually push through like that and have good range and ability to push with that.
So I can bring them down a little bit lower, use my thigh, traction a little bit out there, and then an L to M, either mobilization or thrust.
Yeah. Conversely,
Conversely, we're going to do a M to L, a medial to lateral glide on the tibiofemoral joint. So now I need to get it on the inside of the knee here. I can stabilize him here. I'm going to put him into a little bit of flexion. You can see his heels resting on my thigh. From here, again, I want a perpendicular force to the joint. We're going to go medial to lateral right across. So we can start with just a slight mobilization, kind of bouncing into that lateral to medial, or medial to lateral. And then we can apply a force if we choose to.
Yeah. So depending on your scope, you might be doing just mobilizations or patient tolerance, and if they're okay with it and you feel like it's warranted, then you can go ahead and try that grade 5 mob as well. All right.
Great. Oh, the distraction. Internal external rotation, that was the one we did, right?
Yeah.
You're talking about?
Yeah.
Okay, so, oops. So the distraction of the tibiofemoral, you're going prone, it looks like. I guess I did the...
But that's fine.
Did the...
Like any and all variations you want to toss in there, just because they're not in the book, do whatever you like to use, put that in there.
Okay, I'll do the fulcrum one. Can I take that one into the proximal tibiofibular joint too?
Yep. Make it relevant.
What do you call it? Fulcrum maneuver?
Yeah.
Okay, we're going to be just doing a... Do you call it a posterior and anterior then? Or is it just a...
It's a gapping, P to A gapping is what it is.
Okay.
Yeah.
We're going to use a posterior to anterior gapping maneuver. We like to call it the pump handle or the fulcrum maneuver. So you have a few options here. I like to just use my hand, kind of the web of my hand and the bulk of my hand. So we can use it in two different portions here. We can use it on the posterior aspect of the tibia. And what we're gonna do here is we're going to actually do this type of a force. So what I'm doing is a posterior to anterior right up here at the backside of the posterior or proximal tibia, and then an anterior to posterior on the distal tibia. So we're gonna take that to end range, meaning I'm going as posterior to anterior as I can on the joint, bring it to end range, and then we do that little bit of a pump handle maneuver.
Yeah. And it doesn't have to be a thrust too, like do it
Yep.
as a mob to start.
So we can do this as a mobilization.
Yeah, and it doesn't look like much is happening right there, but because you have this fulcrum advantage, you can feel knees gap really well with that. So
If you have a smaller hand or wrist, you can kind of put that wrist joint right underneath, and that gives a little bit more bulk to it.
And if the patient has good flexibility, what you can do is you can even bring them up more like this, and then you're pushing more down onto their limbs. You're using gravity as an advantage.
So let's use that one for a proximal tibiofibular. So the only difference here is I'm going to start right at the backside of the tibia, sliding out medial to lateral onto the backside of the proximal tibiofibular joint. We're going to take it to that end range and do a little bit of a thrust.
Yep.
Again, we can mobilize that just like that.
Yep. Good.
Okay, I'll get your face down.
Okay. Other variations, flip your patient over.
So we can do a tibiofibular distraction in this position, and we're gonna go again into that knee joint as close to the crease as possible. I like to kind of clasp my hands in this position, and then we're just pulling essentially superior to inferior in that position. We can do that as a mobilization, just kind of bouncing at that end range.
Yeah, and then also show the fibular mobilization here. You can do the same way, right?
Just going more laterally.
Yep.
So going on to the proximal tibiofibular joint, we can move more to the lateral aspect, and now we're just hooking on that proximal fibular head and doing a little bit of a pull.
Yep, or a mob as
Or a
well.
mobilization where we just bounce that joint.
And again, one thing I'd encourage, stay set up there, Amber. One thing I would encourage is she's set up here, so put your hands back on and everything's rolling. Okay, so she's here like this. So you can start with the knee pretty much at 90 degrees, but if she flexes my knee forward more, flexes me forward, you can find different areas and specificity of restriction of motion that you might offer better benefit for your patients through checking these alternate ranges. And this is a strong position because the shoulder's being worked. Shoulders being used to stabilize that tibia. Easy on the practitioner, strong position for the patient.
Perfect. Patellofemoral.
Sure.
Okay, on your back. So we're going to do 4 directions of patellofemoral joint mobilizations. We're going to use mobilizations more often than manipulation on this joint. So starting with just the lateral to medial, I like to line up my thumbs right on the lateral aspect of the knee joint. We want them in a little bit of flexion so they're not locked out. That would lock the patella in the quad tendon. And from there, we're just going to apply a lateral to medial force back and forth.
And so again, it usually doesn't happen this way with this lateral to medial, but if a patient has significant apprehension, it rarely happens again, a dislocation of the medial side. This would be contraindicated, but if they did have lateral patellar subluxations or dislocations, this could be an indicated treatment for that.
So we'll see this a lot with any patient that has iliotibial band syndrome or just adhesion between the IT band and lateral quad. So this is a commonly used mobilization.
Yeah.
I'll use the opposite knee for the medial to lateral mobilization. So again, using that double thumb on the inside of the kneecap, and we're just going to do a medial to lateral force.
Yep, nice.
For the superior to inferior, we're going to go on the top of the knee. This would be indicated for any time a patient has a more superior tracking patella or distal quad adhesion.
Also known as patella, not Baja, Alta, A-L-T-A, okay?
Alta.
Yep.
So we're going to do that double thumb. I like to reinforce this one so I'm more in that position, and we're just applying that downward pressure, superior to inferior, mobilizing it.
Yep, or another option to reinforce could go with the thumb contact and then the full hand over top as well. Great way to reinforce there too. And you can really feel good traction with that, so nice.
And the last one would be the inferior to superior. Anytime the patient has maybe overuse in the patellar tendon or patellar ligament, we're going to traction it a little bit up. So I'm just hooking a bilateral contact here. I could also use a reinforced contact going inferior to superior along the femoral.
I mean, intercondylar groove of the femur. Yeah, totally, right?
Along the intercondylar groove of the femur.
Yeah, and so when you're pushing up like that, what you might see as a positive, it can be painful on some people. If they have degeneration or chondromalacia patella, that might not be the best mobilization for them because you do tend to grind the patella into the femur with that.
This is a good at-home exercise for patients also, where they can, just be sitting in an L-sit. He can come sit up, and I'm just going to demonstrate to him. He can actually just relax the quad, and then just kind of wiggle back and forth, up and down by himself at home with some home care.
I'm doing it, coach. All right, thanks, doc.
Perfect.
Okay.
Okay, we have a anterior to posterior glide of the proximal tibiofibular joint. So what we're going to do here is we're going to do a thenar contact and thumb contact along the vertical of the proximal fibula, and then what we're going to do is we're going to reinforce it, and we're going to be just applying, I like to again hold the knee down or the foot down, and if we can apply an anterior to posterior mobilization, and then if we want to do a bit more thrust on it, a grade 5 manipulation, we're just going straight anterior to posterior on this lateral portion of the proximal tib-fib joint.
Yep, and the key thing is making sure to keep that force, just like Amber did, over top of the head of the fibula, basically. Yeah.
The opposite of that is going to be a posterior to anterior on the proximal tibiofibular joint, and I like this one. I like to actually hook my fingers on there. Can you scoot down just a tiny bit? Good. There we go. We'll curl your toes. We're going to hook on the back side of the fibula. We're going to stabilize on the front side of the knee. And what we're going to do is we're just going to pull. So we can start as a mobilization here. If they have any hamstring tension, obviously attaching to that fibular head, that's going to be maybe a little bit sore, but still probably indicated. And then anytime there's any lateral knee pain on a patient, this is also indicated. So we can apply that posterior to anterior force.
And the only other thing to watch there when you're pulling on the head of the fibula like that is remember the common peroneal nerve runs around that area. So if you get any numbness and tingling down into the toes, into the feet, you're probably compressing that nerve. So just be aware of that.
Excellent. And then superior to inferior. What would this increase in terms of range of motion?
It wouldn't really. And even if you
Not
look at this, yeah.
Okay.
Yeah.
So a superior to inferior glide on the proximal fibular head. I like to again use kind of a calcaneal contact on there, hooking through the heel of my hand. I'm going to stabilize here at the knee, and I'm just going to traction the fibular head superior to inferior, kind of bouncing that joint end play. If I want to do a force on it, a manipulation on it, we're just going to do one force, and we're going down the bone. So force just like that.
Yep, good. Keep in mind this tibiofibular joint is very fibrous, so you're not going to see a lot of movement with it.
Ankle.
Yeah, let's bang it off really quick. You're doing great. Like this we'll be done, and then when Drew gets back, we'll be ready for shoulder and all that, so it'll be perfect. Yeah.
Okay, tibiotalar distraction. I never do it from this way.
I know, no one does, but it's just a way to show it as a variation.
So if I was just doing it, we're in this position, and how do you generate enough force just being low?
You gotta be in a lunge, and you gotta be ready to push. Yeah. And in fact, what did I do for the picture right there? What I really did is I hooked around both sides, and
like that.
You can, yeah. So you could do this. You can push with the web of your hand, or you could push with the heel of your hand too.
Okay.
If you held me up.
Okay.
And those are all variations, so we can show those.
Okay.
Okay.
So we're going to do a tibiotalar.
You know what? Just wait. I'll back up a little bit.
Oh.
Put you in the center here. Good chunk. All right, boss. Let's do it.
Okay, we're going to do a tibiotalar mobilization. So we're opening up that talocrural joint. My personal preference is going to be a contact. I'm going to take the middle finger and the thumb, and I'm going to hook just to neutralize the ankle. I'm going to then take the back of on the Achilles area. And what I'm going to do here is, again, I might get my patient to hold the table. And I'm going to apply first just a superior to inferior mobilization. If they're feeling really jammed up in the joint and we're trying to increase that global range of motion with this manipulation or mobilization, we can actually apply a thrust.
Yep. And another variation on that could be the same setup.
Yep.
Instead of actually gripping around the heel, you can take one hand, reinforce with the other hand, and then thumbs up just like Amber's got right there.
So we're just a double reinforced, kind of hooking that middle finger right on top of the ankle joint and then pulling straight back towards us.
And one thing I'll say about this setup too is if your patient has knee instability, you might be slightly contraindicated to do this, but what you can have them do is contract their quads and hamstrings and then try and relax their ankle, and you can still get a decent amount of force if you have that extra muscular stability around the knee joint. So just something to consider.
Right. We can have one more variation where we go from this top position. So I'm going to use the heel of my hand on the top of the ankle joint. I'm going to reinforce on the bottom. You can see my forearm in line with his tibiofibular. And what we're going to do from this position is, again, just traction. We can mobilize going superior to inferior, and we can also apply manipulation with a force going that way.
And then one other variation on the hand hold, she can go top hand where it was, but then bottom hand under the heel like this, and then driving forward the same way. So both hands are tractioning right on that full foot and ankle. Yep, nice.
Anterior to posterior talar push. Do you like to do it primarily in this position?
Doesn't matter. Or even if you put it up on your thigh or something like that, whatever you like.
Yeah, I'll do it from here.
Okay.
So we're going to do an anterior to posterior mobilization and manipulation on the talar joint, on the talocrural joint. So from this position, this is actually going to be what increases dorsiflexion of the foot. So super important in many athletes and people on their feet a lot.
Yep.
So from this position, what I'm going to do is I'm going to be kind of hooking in right into that ankle crease. I'm going to bring him into slight dorsiflexion here. I'm not going to end range by any means. Just bringing him up to that 90-degree angle. And from here, I'm going to stabilize him, and I'm just going to apply a downward force, which is an anterior to posterior force. And from here, if I want to do a manipulation, I can do a force straight down to the floor.
Yep, and another variation would be even to put the ankle just slightly on the table like this and repeat the same forces. So that stabilization with her thigh right there is good because it keeps the foot from wobbling around, right? And you can just see how strong that looks.
And I can apply that downward force right through here, stabilizing also with my hand under the tibia here, just mobilizing and then applying a force.
Yep, nice.
Do you do a posterior anterior on this, I assume?
Yep.
So you use the tibia here?
Yeah.
Okay. Or...
Because whenever you can put the heel on the table, I don't have to control your foot now, right? I don't have to fight gravity or anything. I'm created a strong bridge to work off of.
Okay. So next we're going to do a posterior and anterior on the talocrural joint. We're going to actually use the tibia. So we're going to be applying an anterior to posterior force on the tibia and just stabilizing that tibio-talar joint.
Yep.
So from this position, I can mobilize. I'm going anterior to posterior on the distal tibia.
So just to be clear, compared to the last one that we did, yep, stay set up. She's pushing down through this hand as most force. That's just stabilizing the foot.
When I go to actually do a manipulation, I might actually pull up a little bit with this one and then apply the force that way on the tibia.
And one key thing, look at the way Dr. Amber set up here. She is sternum over contact. Look at the V shape in her arms. That's a strong way to perform this adjustment. Okay.
Do you want the variation of that?
Yeah,
face
totally.
down? Okay.
Yeah.
Can I get you to flip face down? So the variation of this would be to actually contact the posterior talus, if you can get into it. Yeah? Would you even you wouldn't even be able to contact it.
No, but you'd be doing it through the calcaneus,
okay.
right, is what you'd be doing.
Okay, so we're going a force through the talus here, posterior to anterior, but through the calcaneus. So we're just on the back side of the ankle. I'm going to stabilize the distal tibia here, and then from here you can see his heel right up against my knee. That's just to keep the ankle in neutral. From here we're going to just apply, apply just a mobilization, and then from there if we want to apply a force we can. And I'm doing a little bit of a pull up on that tibia and then a posterior and anterior on the heel. Yep,
excellent.
Medial to lateral talotibial. Oh, so what are we going on here? Same thing.
Yeah, it is. You're just changing the way that you move your hands, right?
So this one are you doing more of you're just putting it in a bit of rotation.
Yeah.
Is that what's happening?
Yeah. So what you're doing is you would take your first hand, you're going to go ahead and load in, reinforce with the opposite hand in the same direction, right?
Okay.
Yeah.
How do I describe this one?
Well,
medial to lateral. Is that my?
Yeah. So let's say you had a patient come in and they've done. So we'll go through this. So we're going to look at some medial and lateral mobilizations here. So one of the key things to get is you've had a patient who's done an eversion ankle sprain, so they've everted like this. Maybe you want to actually induce some inversion with that action. So how do you induce inversion?
So we're going to pull some tissue slack medial to lateral to open up more of the lateral aspect of the tibiotalar joint. And so I'm going to reinforce with that middle finger again. I'm going to pull to open that joint up, and then from there we would apply a little bit of a traction, holding on to that tissue slack. So we're just applying a mobilization. Again, if we want to do a manipulation, we can just do a little pull at that end range.
And it depends on the size of the patient and your size and how hard you're going to pull. If you want, you can have your patient anchor down. I'm holding onto the table a little bit here. Now you've got a patient who's come in with a much more common inversion ankle sprain. So what do you probably want to do?
Do the opposite of that. So we're going to do a lateral to medial tissue slack here, pulling across and reinforcing that. Just really trying to open up the ankle joint, doing a bit of traction on it, keeping that tissue slack nice and tight, and then from there I can apply a manipulation.
Yep, solid. All right, okay, I think we're almost done here. Good thing Jameson showed up right now.
Here you guys go.
Subtalar, medial, lateral to medial. Reinforced digital pull. I do not know how to do this.
Well, basically, what you're doing is that was basically what you just did there already.
Oh, okay.
That's a reinforce, but you can also do. I got a little bit of reflection on there. You can also do thumb contacts as well. So you can actually take individual bones and move them by putting your thumb on it and then pulling
just
through or pushing through.
a superior to inferior drive.
Yeah.
On
exactly.
any of the bones.
On any bone. So yeah.
Okay.
And you could also show it in this position too, where you push down onto the foot as well, right?
So we would just be reinforcing.
Yep.
Like that.
Yeah, and you would, but basically what I would do is put my thumb like, thumb
on the contact.
Thumb on contact, reinforce, pushing down. Yeah, and we'll demo with the other foot, of course, so people can see it.
So what should I describe that as in terms of which bone?
Yeah, so you can basically say any of your tarsal bones that you want to mobilize, you can go ahead and use this contact in two different variations. One is going to be like this, finger landmarks, reinforce and pull, any bone you want, and then you can do another variation straight down in that position.
So which bone should I demo for purposes?
I would go navicular probably.
So more medial?
Yeah, navicular, or say some of the cuneiforms. Cuneiforms will probably be easier for you to hold actually, say medial cuneiform.
And then we have the two contacts.
Yeah.
Okay. Okay, so we're going to do demonstrations on, oh my god, what's it called?
It can just be any tarsal. It can be any tarsal bone that you want to mobilize. You can use these techniques. You can even go to a ballotment if the person has a really mobile foot. But let's go ahead from here.
So we're going to mobilize in this position the navicular bone. We're going to be doing a superior to inferior force or a dorsal to plantar force in this case. So I can do a contact right on the navicular bone. I could also use this on any other tarsal bone. And I'm going to reinforce it, keeping my thumb as neutral as possible. And we're just going to go with that downward force, kind of mobilizing it, trying to increase the global range of motion in that joint on all three sides of it.
Look at her setup right here. Sternum over contact, good body weight, good force, easy on the practitioner, good force into the foot. Yep.
We can also do a second variation, which is a reinforced variation, very similar to our ankle. Before we were right at the ankle joint, now we're going to move down to that proximal row of tarsals. So going on to that navicular, I can reinforce it and just start by mobilizing it with that superior to inferior direction.
Yep. And again, it could be medial cuneiform, lateral cuneiform, cuboid, all can be mobilized like this, right?
And we can just move our contact out based on that.
Yep, absolutely. Okay.
Subtalar distraction. I would do that as this guy.
Yeah, totally.
Yeah, okay.
Yeah.
So next we're going to do a subtalar distraction. We are trying to get the joint between the calcaneus and the talus. So from this position, I'm going to take my outside hand. I'm going to hook right on that joint line. I'm going to reinforce on the top. And what I'm trying to open up is that joint right there. So I'm going to start by just mobilizing. And from there, I can do a manipulation by pulling superior to inferior.
Nice.
You got a cracky foot.
I do. Yeah.
I also do, I don't know if you have these in the book, but I have
But do whatever, like anything
Okay.
you want to do, just start doing it.
Go on your belly.
Okay.
So other ways to mobilize the subtalar joint, what I like to do is kind of just put their toes right up against your core. We're going to hook a double middle finger on the backside of the subtalar joint. And from this position, it's very similar to the patellofemoral joint mobilizations. We can actually just increase the overall glide by going back and forth, forward and back, and medial to lateral, lateral to medial.
And especially as the toes are anchored on the practitioner's body, you can see how much more force, like I can feel my calcaneus is moving around like crazy right now. That's really great. Yeah.
We have a lot of patients that, complain of heel pain, heel spurs, and a lot of that comes down to not having the flexibility in the foot. So we need to increase the overall mobility of the foot and tarsal joints.
Good. First, and then away you go. Yep.
Okay, so we are going to do an I to S, inferior to superior force on the bottom of the foot. This is going plantar to dorsal. And what we're going to do here, this would be good for anyone that's had a fallen arch. We're trying to increase the overall mobility in the mid-foot here. So we're going to take our contact. We can use a thumb contact to just be specific with a reinforced backing it up. I'll go on the navicular here for ease of viewing. So getting that inferior to superior force here, I'm going to use my knee up against his leg, and we're going to just take him into plantar flexion and to that end range there. I'm going to get a bit more over my contact there so that I can apply a bit of a mobilization. So doing a bit of mobilization there through my thumb, and then if I want to do a manipulation on that, I can do a drive through like that.
Yep. And again, you could have fallen arches, plantar fasciitis, any kind of foot issues. This may offer benefit. At the very least, even the compression of your hand can cause increased blood flow and local nerve stimulation that could offer benefit.
Yes.
Okay. Yes.
Do you want to say the same one for the transverse arch? Sure.
So we can also move our contact up to the transverse arch. This is more getting into the forefoot here. This would help just open up the metatarsals and just using that same thumb contact and then reinforcing it, hooking my knee there, taking him into plantar flexion, and then applying that mobilization along the axis of his foot or the metatarsal.
And the key thing for this to be safer for the patient is that her thigh is on the table, so I can feel more secure. I'm more likely to relax as the patient for the practitioner.
And then we can apply a manipulation through that head of the metatarsal.
Yep, solid. What about toes? What can we do for toes,
Yeah,
Doc?
do those for sure.
Okay.
You can pop every one of them.
What do we do for toes?
So the most common dysfunction we're going to see in the foot is going to be at the big toe, at the first metatarsal phalangeal joint. First and foremost, just applying a traction to the big toe is going to be key. You want to make sure you're stabilizing the rest of the foot at the metatarsals. And then what I like to do is take my thumb and go right parallel to the phalange. And what we're going to do is just apply just a bit of a traction on that big toe. If we want to do a manipulation, we're going to just pull at that end range. We can apply that same force at any of the 5 toes.
Yeah. And for a lot of patients, just nice gentle distraction into their feet, they just love it. It's just a great way to go. Another thing is you might see a lot of hallux valgus potentially, and you could do mobilizations from medial, so from lateral to medial as well, to actually grab the big toe. So you're actually going to grab the big toe with your whole hand even, using your thenar eminence, even down just a little bit. Yeah, like right there, squeeze it, stabilize, and then bring it out to the side this way. Yeah. And I've done this with patients who have significant hallux valgus. You have to work slowly, but you can apply extreme forces here and start to loosen up some of the tissues on the medial side of the foot. Can offer potential benefit there as well.
So it has a tendency to want to go this way. We're trying to neutralize it back into that position.
Yeah. It can be extremely painful, so make sure you have good consent with your patient before you do that. I'd also combine that with some instrument-assisted techniques, but either way, you can make differences on somebody's foot with mobilizations and other soft tissue techniques. Easy out. Okay.
What do you think?
Yeah.
Tiny little joint. Like
Yeah. You're gonna rip the toe off. Yeah.
So we have a double thumb contact, which we can use to traction any of the toes. What we're going to be doing is pulling towards me and then kind of flicking it back.
But to start, we'll do a mobilization to begin with, okay? See how the patient tolerates it.
So we're going to just test it on the patient.
Yeah. And you can feel like good stretching of the tissue when she's doing that. Yeah, excellent.
This is good, especially for anyone that maybe doesn't activate their toes properly and is always kind of in that curled position. We want to really open up those joints. So to apply the manipulation, we're going to.
Yep.
No more pops.
All right, yeah. Use them all up. We gotta wait 20 minutes.
So next we're going to perform a metatarsal glide. We're just trying to get some space in between those metatarsals. What I'm going to do is take a double thumb and thenar contact, and I'm basically going to be going up and down along 2 metatarsals and trying to spread them apart. So if I start more medially between the first and second, I'm in this position, spreading. So I'm kind of breaking the bread motion.
Yep.
And I can mobilize, working my way across the foot.
And the key thing to get is she's spreading with her thenar eminences, but also pushing with the fingertips at the same time to get force on both sides of the foot. It's whenever you can, if you can get a force on 2 sides of a joint, you're going to have a much higher rate of success with that.
So if we want to apply manipulation, usually through the midfoot in this position, we're going to be spreading first, take it to end range, and then thrusting. So I'm doing that type of an action. We can also do it in this position. So I'm going to hook on the bottom here, and I'm going to be pushing in while I spread those metatarsals.
So good mobilization. Again, sternum over contact. She's pushing down into the foot as she's doing that. Easier on the practitioner. And if it was going to be an actual grade 5 mobilization,
take it to the end range and thrust.
Yep.
So the thrust is going to come from my thumbs and thenar eminences.
All right, excellent. All right, okay, good stuff. So hopefully you found this useful. I want to thank Dr. Amper for coming in to do this joint mobilizations with us here, and we'll catch you on the next video. Thank you very much.